Welcome, and thank you for joining us today. My name is Ellen Wilson, and I'll be the moderator for this expert briefing for the media, which is hosted by the Johns Hopkins Bloomberg School of Public Health. Now that nearly 50% of Americans are fully vaccinated, and many states are easing restrictions, this briefing will feature leading experts who will discuss the potential consequences of the Delta variant in the US, how vaccination can mediate its effects, and how long-haul symptoms of COVID-19 could impact recovery in the US and globally. The World Health Organization has sounded an alarm about global deaths from COVID-19 reaching 4 million as the Delta variant spreads to more than 100 countries. Please note that participants are welcome to use images, video, or quotes directly from the briefing, and that the content is for immediate release. First, I'd like to briefly introduce our two speakers. Dr. David Dowdy is an associate professor of epidemiology at the Johns Hopkins Bloomberg School of Public Health and a physician with Baltimore Medical Services. He serves as the track director for infectious disease epidemiology at the Bloomberg School. His COVID-19 research has focused primarily on the role of antigen-based testing in low and middle income countries, as well as the adverse impacts of the pandemic on the management of other infectious diseases. Dr. Priya Duggal is a professor of epidemiology at the Johns Hopkins Bloomberg School of Public Health. Her primary research is on the intersection of host genetics and infectious disease. She leads two COVID-related projects, one of which pertains to the study of long COVID. We will have time for questions following our panelists' remarks. The procedure will be as follows. We will take some questions that have been submitted in advance of the briefing and some from the Zoom chat. If you have a question during the briefing, please enter it in the Zoom chat addressed to all panelists. Please enter your name, media outlet, and question. We hope to cover as many as possible. Just to note that participants will be muted during this briefing and it will be recorded. Dr. Dowdy, please go ahead.
Thanks so much, Ellen. I want to start by giving an overall picture of the pandemic at the present time. Over the past 2 months, transmission in the US has been at its lowest level since the start of the pandemic. This is largely attributable to vaccination, with nearly 60% of adults in the US being fully vaccinated. And of those who have not been vaccinated, probably over a third have been infected and are also likely immune. But even this level of immunity is not enough to guarantee that COVID rates will continue to go down. In the US, even though cases were consistently declining throughout May and June, the number of cases has more than doubled in the past 2 weeks alone. And it's possible that things can get much worse. In the UK, for example, vaccination levels are similar to here in the US, but in the past 6 weeks there, the number of COVID cases has jumped tenfold. So even though over the past 2 to 3 months, I think it's been very reasonable for us to start engaging in those social activities that are so meaningful to all of us, I also think it's now reasonable to think about reinstituting measures, being a little more careful to make sure that we don't have another major wave of disease on our hands in the next month or so. As cases have started to rise again, there's also been a lot of talk about the Delta variant, which does seem to be more transmissible than previous variants. But it's important to recognize that seeing more transmissible variants over time is completely expected. This is the natural course of any infectious disease. It's hard to know how much of the current increase in cases is due to the variant versus changes in behavior as our society has opened up. And just because a place like the US has the Delta variant around doesn't mean that a major wave is inevitable. In Canada, for example, the Delta variant has been present since March, but cases there are still declining. But regardless of how much of the current surge is due to variants versus behavior, it's important to know that there's no evidence that current vaccines are any less effective against the Delta variant. So even in places like the US, where the Delta variant has become the dominant strain, vaccines still work and work very well. This is why we've seen the vast majority, over 90% in some places, of serious COVID illness and death occurring among people who are not vaccinated. So even with the Delta variant around, every person vaccinated is one step closer to normalcy. We also, I think, need to keep the current burden of COVID-19 in perspective. Right now in the US, about 2 to 3 times as many people are dying of COVID each day as in car crashes. That's a tragic amount of death, but not out of proportion to other major health problems that we have faced as a society. It's important that we recognize that COVID has the potential for explosive outbreaks and also to cause devastating long-term consequences, as Dr. Duggal described. Also to recognize that COVID is going to be with us for many years into the future. But we also shouldn't be panicking. Thanks in large part to vaccines, COVID is now a much more manageable problem than it was even just a few months ago. Also, as much as cases are going up here in the US, we need to remember that things are much worse in other parts of the world. For example, in many parts of South America, like Argentina, 10 times as many people are dying of COVID per population as here in the US. So even if things have been more normal for us here in the last few months, that's not the case for billions of people living in harder hit countries. And as long as the virus is circulating, mutating in other countries, it's going to be a threat to us here too. So in summary, vaccination and natural immunity have combined to get infection rates down over the past few months. And since the majority of our population is now immune, it's unlikely that we're going to return to the massive nationwide waves of disease that we saw back in April or in January. But cases have started to go up again, and it's clear that major outbreaks can still occur, especially in communities where vaccination levels are still low. So we need to remain vigilant and be willing to take measures to prevent outbreaks where case counts are starting to increase again, but without panicking or worrying that we're going to be back where we were in the past winter. This is thanks in large part to vaccines, but we've come a long way from where we are then.
Thank you, Dr. Dowdy. Now we will hear from Dr. Duggal. Dr. Duggal, please go ahead.
Yes, thank you. Well, I think that Dr. Dowdy gave us a lot of information currently about the state of the pandemic. And I just want to take us back a little further to about 18 months ago when this pandemic started to emerge here in the United States. And our biggest concern really was the enormous number of individuals who were dying from COVID-19. So in certain time periods, our hospitals were overrun in certain cities. People couldn't get the care that they necessarily needed. We were short on PPE in many places for our healthcare workers. And our primary focus was those older individuals who were at the greatest risk of death, mortality. But since then, and because of the vaccine and because of many of the measures that we've taken across this country, we've been able to control much of the rising mortality. So we still, as you just heard, have areas or pockets where that is increasing. But for the most part, it's somewhat under control. And that gives us a moment to think really about the other side of it, which is the morbidity from this disease. So with many infectious diseases, you have an acute phase. That's that initial phase where individuals may recover or resolve their infection, or they may go on to severe infections and potentially death. And then we often have what we call the chronic state of infection. And that's what we're starting to see emerge in very large numbers for COVID. These are individuals that we call having a post-acute sequelae or having long hauler symptoms. The symptoms that we see with long COVID are varied. So we have things like loss of taste or smell, and we also have things like brain fog or an inability to concentrate. We have increased anxiety and depression throughout the pandemic, but also in individuals who didn't report this prior to being infected. We also have individuals with new heart conditions, new kidney conditions, and most prevalent, individuals who have excessive fatigue and trouble or difficulty breathing. These are all real symptoms that we're starting to see across the age spectrum of individuals who are infected with COVID. And what's really interesting is, and perhaps more devastating, is that we're also seeing it among those individuals who were mildly infected, moderately infected, in some reported cases, those who were previously asymptomatic, as well as those who were hospitalized. So no matter what kind of infection you have, the overall reports that we're seeing come in globally is about 30% of individuals who were infected with COVID-19 are reporting symptoms more than 30 days post their infection, some more than 3 months, more additional ones more than 6 months, and some people now reporting symptoms a year after they were infected. Of those individuals who were infected, we see that perhaps about 5% or so, and this number is not really clear to us yet, are actually reporting debilitating symptoms, where they can't actually function in their daily life, which affects both the economy, their workforce, and their caregiving opportunities. Here at Hopkins, I'm leading a study that is working with my colleagues, which is actually trying to quantify what's happening with long COVID. It's a simple survey that's available on the web with the goal of enrolling 25,000 individuals, and we have 30% enrollment already. What we don't know is really what the numbers are supposed to tell us. We don't know who's actually infected and then has long COVID symptoms. Ideally for us, we get anyone who's ever had an infection in the United States of COVID that reports into us, so that I can take a 30-year-old woman who doesn't have long hauler symptoms and compare her to a 30-year-old woman that does have long hauler symptoms to see what they share and perhaps what they don't share, to give us some clues on what some of the risk factors are. What we are seeing from some of the studies, though, is that the age range of who's getting affected tends to be a little bit more on the spectrum of younger individuals. So people in their 40s, 30s, 50s are actually having long-term symptoms. We see that younger women versus younger men seem to be reporting more infections, but more long hauler symptoms, but it's not clear if that's just a reporting issue or if that's actually a difference that we're seeing, because we don't see that difference reported at the older ages. We don't know if there's a difference by race or by other comorbidities. And all of these are really important, because until we get a handle on who's at risk for long COVID, it's going to be very difficult for us to understand who we should be treating. And until we get a handle on what the symptoms are and the spectrum of symptoms for long COVID, it's especially going to be difficult for our healthcare workers to address it. And so there are multidisciplinary clinics that have emerged across the country, primarily at academic centers, that are trying to address long COVID symptoms, but it probably will not be enough for the enormity of individuals, 33 million that have been infected in the United States. So in sum, long COVID really is real. It is the counterpart to those who have that have unfortunately not made it through and have died from COVID. Now we have a whole group of individuals who have survived COVID, perhaps with very mild infections that are going on into a chronic state that will likely be with us for a really long time, both here in the United States and globally.
Thank you, Dr. Duggal. Now we will take questions. If you have a question, just a reminder to put it in the Zoom chat with your name, media outlet, and question, and to whom you'd like to address your question. Here's a question from Howard Schneider at Reuters for Dr. Dowdy. Going back to the early days of the pandemic, there seemed a sense that even with vaccines, COVID-19 in some variant form would be part of the health landscape in perpetuity, like waxing and waning on a cyclical basis. Is there any further clarity on the life cycle path of the virus now? For example, in the US, will the expected level of background infection and fatality remain below some critical threshold that avoids stress on the health system and the need for new restrictions on activity as opposed to personal vigilance?
So thanks, Howard. This is a great question. I do think that what you're describing here is likely what we're going to be seeing in the coming years, that this is not going to be a disease that is eradicated in the next few months. This is going to be something that we have to, as a society, learn how to deal with, coming and going over a course of probably many years. It's also clear that even with reasonably high rates of vaccination and immunity as we have now, we can still see outbreaks of disease. So we are going to see some of this ebb and flow over time. I think that we need to be willing, again, as a society, to deal with this, that when cases are going up, that we adjust our approach accordingly, and when cases are going down, again, that we perhaps open up a little bit more. I don't think that we're going to be going back to where we were this past year when the vast majority of the population was not immune, but I think as a society we need to be prepared for dealing with this disease for many years to come. and the natural ebb and flow of that cycle.
Great, thank you so much. Here's a question from the Wall Street Journal for Dr. Duggal, from Denise Rowland. What do we know right now about the effectiveness of vaccines in preventing long COVID?
Yeah, that's a great question, and one that I think many of us really hope to get an answer for. I think it's a little too early. What we do know is that there are some what we're terming breakthrough infections post-vaccine. The number isn't large, at least not reportedly large, and we are hearing that those individuals who have those infections have symptoms, traditional symptoms of COVID. It's just that they're mild or moderate, and in some cases asymptomatic. Given that they can have those symptoms, it's likely that they can also go on to long COVID. And that's the piece that we're not really sure about, though, because we don't really know how long COVID starts. We don't know the mechanism. So there are lots of speculation on what could be causing long COVID. But at least at the moment, if you can have those symptoms, we believe that you potentially could go on to have long-term symptoms as a result of it. I think that, studies like ours and others that are following these patients or asking these patients how they're doing several months later will give us some insight in the next few months.
Thank you so much. And here are questions from Sumati Reddy at the Wall Street Journal. The first question is for Dr. Dowdy. Are the symptoms presenting with the Delta variant of COVID different from the symptoms we saw from the other variants?
Thanks, Sumati. So I have to say in this case, I think it's a little too early to tell. It's important to recognize that the Delta variant has really only been seen at scale in large population level fashion for probably the last 2 to 3 months. And the people who are getting infected now are not the same as people who are getting infected at the beginning of the pandemic. For example, they're younger, may have different contact networks, etc. So I think it's hard for us to say whether the symptoms of of infection from the Delta variant are that different from that of other variants. It is important to recognize that while there is this pressure for viruses to become more transmissible over time, there's not necessarily the same pressure for them to become more virulent or more severe in their manifestations. So I think we'll find out in the next few months whether these symptoms differ or not. But there's no reason to worry per se that these symptoms are going to be much more severe due to the Delta variant as opposed to the preceding ones.
Great, thank you. Here's a second question also from Sumati for Dr. Duggal. Is there any indication that the percentage of people who are fully vaccinated and get COVID will have a less likelihood of getting long COVID? Or do we anticipate that 10 to 30% of breakthrough infections will result in long COVID?
Yeah, so similar to the other question, I think it's really too early to know. I think what we do know is that individuals who are vaccinated are less likely to get an infection in general. We've seen that, at least not a severe infection. We know that for fact. But data out of Israel suggests that if you're vaccinated and you're surrounded by lots of vaccinated individuals in your community, you're less likely to have an infection. And so in that sense, the odds of you actually getting infected drop the more that people are vaccinated. That being said, if you are vaccinated and you do get infected, not reinfected, but infected, we don't know what it will mean for long COVID. And so we'll have to assume that it's somewhere in that range of, say, 5 to 30% of those individuals could have long COVID symptoms.
Great, thank you. Here's a question for Dr. Dowdy from Jane Miller at WBAL TV. Can you discuss the efficacy of the vaccines against the Delta variant?
So again, great question. And again, it's important to recognize that we're still getting these data, that the Delta variant has really only been seen at a large scale for the past couple of months, and in places like the US really has only started to take over a large fraction of infections in the past month or so. We do have evidence from the lab that all 3 of the vaccines that are currently in use in the United States, at least, seem to develop a robust antibody response to the Delta variant. All three companies are saying, at least to us, that their vaccines are effective, and there are some studies with small sample sizes that suggest that at least a full course of the Pfizer vaccine is equally effective against the Delta variant, and there's no reason to suspect that that's any different for Moderna or J&J. I think we also have very strong circumstantial evidence that these vaccines are working, because even now in the US, where the Delta variant accounts for most of our infections, we're seeing that the vast majority of cases, serious cases, and especially deaths are occurring in people who are not vaccinated. So it looks like these vaccines are working. And I think the bottom line is that there's no evidence that these vaccines are not effective against the Delta variant, and we have every reason to believe that a full course of vaccination with any of the currently available vaccines is likely to be highly effective, especially against severe disease, against any infection caused by the Delta variant.
Great, thank you. Here are questions from Sarah Blazonis at Spectrum Bay News 9 out of San Francisco. The first question is for Dr. Duggal. On long COVID, there have been reports on the possible development of a test that can tell patients whether or not they have long COVID by detecting autoantibodies. What benefit do you see this possibly having for long haulers? Can having this information better shine a light on treatment options and possibly lead to recovery?
Yeah, that's a great question as well. So it will be the most fantastic day when we can definitely tell people that from a simple blood test, you are likely to have long COVID or not have long COVID, for multiple reasons. One, because many of these patients sort of feel like their voice is not being heard, that they have a myriad of symptoms and that people don't know what to do with them. And so having a clear definition will be wonderful. The second is, if we can actually identify a factor that we can test for, then we likely can develop a therapeutic or treatment to treat these individuals. The tests that you're referring to are autoantibodies. So many individuals develop autoantibodies when they have autoimmune disorders, things like lupus or scleroderma. And so what we don't know from these particular studies that have been out there, and this is really just sort of reflective of how the pandemic took us, right, is we don't have pre and post information. What we ideally would want is a blood sample on these individuals before COVID, and then a blood sample on individuals after COVID, so that we would know that the increase in antibodies that we see is a result of the infection and not perhaps because they had pre-existing antibodies, because perhaps they were at risk for an autoimmune disorder. What these studies have shown us about autoantibodies is that people with COVID, including those with long hauler symptoms, seem to have elevated autoantibodies. We don't know how long those last for, so something looking at it longitudinally will really help us. And when they compare it to individuals who report that they never had a COVID infection, they seem to have less autoantibodies. But they haven't compared it to, say, someone who has known autoimmune disease. So there's a couple more steps that are needed before I think we can start to believe a test like that would work in the general population, but it is a wonderful first start in getting us to understand what might be happening with regards to mechanism.
Great, thank you. And a follow-up from Sarah, also for Dr. Dowdy, on the Delta variant. Here in Florida, cases have risen sharply in recent weeks as the Delta variant spreads. Do you foresee some places needing to return to measures like mask wearing, social distancing, regardless of whether or not people have been vaccinated?
Thanks, Sarah. And yes, this is a great question and one that I think many places are grappling with right now. I do want to separate a little bit the question of the Delta variant from that of increasing case counts in general. I think that when case counts are going up, whether due to the Delta variant or not, we should as a society be prepared to take measures to to prevent those cases from really taking off and causing a major outbreak. And in some cases, I think, unfortunately, this is going to require some degree of additional measures, right? But what those measures are really is going to have to be dealt with on a case-by-case basis, right? Depending on how severe this outbreak is. So how rapidly are your case counts going up? What proportion of the population is vaccinated? Those who are vaccinated are protected, at least against all circulating viruses. And so if you have a large proportion of your population that's vaccinated, you may not need to adopt measures that are quite as stringent. Thinking about what the harms are of different measures, right? How much does this affect the economy? What is people's risk tolerance for adopting these sorts of measures? But I do think that we as a society need to be prepared to react when case counts go up, but not to interpret this as meaning that the vaccines are any less effective. The vaccines are still highly effective. It's just that we as a society need to come together when case counts go up to try and prevent them from getting out of control.
Great, thank you. Here's a question also for your Dr. Dowdy from Sarah Sparks at Education Week. What do we know about the impacts of the variant on school-based outbreaks in the United Kingdom? And do you have any thoughts on how schools can best mitigate against any increased risk to children from the variant there?
Thanks, Sarah. And this is, I think, another good yet challenging question. I would not go so far as to characterize the outbreak in the UK as being driven by schools. I think it really is a population level outbreak. But I do think that schools need to take this into consideration. When COVID is spreading in communities, we as a society have an obligation to strike a balance between protecting our kids from COVID and the sorts of potential long-term symptoms that Dr. Duggal has been talking about, and also providing our kids with the education that they deserve. It's a really challenging question, but I think one that we are going to have to address, not just in the UK, but here in the US and elsewhere as schools reopen.
Great, thank you. For Dr. Duggal, here's a question from Tina Say at Science News. Do you see long COVID in children and adolescents? And do you have a time frame for how long people remain ill? For instance, if a person has had symptoms for 6 months, would you expect them to be people still having symptoms a year out?
Yeah, great question. So yes, there are symptoms that are being reported of long COVID in children and adolescents. I don't particularly study that population, but they are reported. They are different symptoms than what we're seeing in adults. But just like with other infections, children can get an acute phase and they can get a chronic phase. And much of it seems to be driven by an enormous amount of fatigue in those children, and an inability for them to do some of their daily tasks. In terms of the length of it, that is a question we really would like to understand. Is this something where you'd have it for 3 months and then perhaps you clear an infection, or you have it for 6 months and you clear it? We are trying to get at those answers. I can say from some of our research, we know that some people have had symptoms for up to a year and they've had symptoms that entire time frame. We know others report that they had symptoms up until 6 months and then some of their symptoms resolved sort of spontaneously or lessened in the last couple of months. So I don't think that it is a definitive that if you have symptoms, 30 days out, you're going to have it for the next year. But what we do know is that if you have symptoms 30 days out, it's likely that it is going to linger from anywhere from, the next couple of months, at least until a year for some individuals. And it really may vary on what those symptoms are.
Great, thank you. Here's a follow-up also from Tina for Dr. Duggal. Are there features of long COVID that are different from symptoms of other post-viral syndromes or chronic fatigue syndrome?
Yeah, so I don't think it necessarily represents what we just see in chronic fatigue. What perhaps is unique about long COVID and is especially apparent because we were in a pandemic, so we were able to witness so many people go through an infection at the same time, is that many different organ systems are affected. So some people are reporting specific heart issues and others aren't. Many are reporting difficulty breathing or dyspnea, and that has a lot to do with the lungs specifically being affected. But there isn't one classic set of symptoms that all of the long haulers are expressing. So we are seeing that it actually can infect multiple different organ systems. Neurologic symptoms, heart, kidney, lungs, they're all being affected and in different numbers for different individuals.
Thank you. And the last question is from Carol Pearson at Voice of America for Dr. Dowdy. How do you expect the Delta variant to affect both teenagers and younger children?
So great question, Carol. And again, unfortunately, as with much of the evidence on the Delta variant, things are still a little bit too early to tell. I do think that we can expect teenagers and younger children to experience a substantial fraction of infections and even disease due to the Delta variant, because vaccination rates in kids are obviously low to zero beyond a certain age. And so I think we can expect that a lot of the infections that are happening right now, which are being driven by the Delta variant, are going to happen in teenagers and younger kids. Whether these infections are going to be any different from infections with the earlier variants, I think still remains to be seen. But just simply by virtue of kids not having the opportunity to be vaccinated at the same level as adults, I think that they are going to experience a disproportionate burden of infection and sickness due to the Delta variant.
Thank you, Dr. Dowdy and Dr. Duggal, for your presentations and insightful answers. We will email the links to the resources mentioned today and shared in the chat. And with that, I'd like to say thank you again to everyone for joining us today.